Hi, and welcome to mini number 4. We're going to go over the calcaneus. So let me just do the slideshow. So on the calcaneus, it is the largest and strongest bone of the foot. The calcaneus is also known as the os calcis. So let me get my little PowerPoint laser pointer. Woo! The posterior part here is what's known as the heel bone. And this little bumpy outie is a tubercle. The whole bone itself is called a calcaneum. And up a little further is called a sustentaculum tali. This is a little ridge that helps support the talus. Now, if you recall, the talus is the bone that connects to the tibia fibula up here at the top. So you can remember talus is the top. Now, the sinus tarsi is this area right here. It's the little groove. And this would be the talocalcaneal joint. So the word itself tells you where it is, talocalcaneal joint. This bone is the cuboid. You have a lot of little tendons up in here, and the biggest one that you have an attachment for is the Achilles tendon, which attaches right here. The Achilles attaches from the back of your leg down here to your calcaneus. So click over here. The calcaneus articulates with two bones, the cuboid and the talus. And you're going to have to know anteriorly with the cuboid and superiorly with the talus. The talus is on top. The one in front of it is the cuboid. So like I said before, the talocalcaneal joint, there are articular facets that appear in this joint, and we'll go over them in just a second. But this is all that provides support for the weight-bearing joints that are in your foot. Doot. Oh, go forward. Go forward, slideshow. I believe in you. There we go. So here's looking at the calcaneus and the joints that are involved in it. It has three facets: the posterior, because it's the one in the back, the middle, and then the anterior. This is the back and this is the front. So this would be the posterior part of the calcaneus, and this is the anterior part of the calcaneus. Here we can see the bones in a little bit better. The cuboid, which is anterior to the calcaneus, and then you have the talus. This whole bone right here is the talus, is superior to the calcaneus. And right up in here is this sinus tarsi. It's just a little groove, a little divot. And over here you see the navicular bone, which is beside the cuboid bone. Excuse me. My slides don't want to go forward. There we go. Okay, so the calcaneus, positioning for the calcaneus is kind of fun. The first position that we have is an axial position, and it is called planto-dorsal. All right, and I'll show you a picture of that here in just a second. Plus the lateral. Now the lateral is the easy one. We'll get into the lateral after the end. So technical factors are 40 inches. You can do it on an 8x10, but of course our IR is a little bit bigger than that. Now, here's what I want you to notice is you increase the KVP range by about 8 to 10 over other foot projections. And this is because you are shooting through thicker bones in the calcaneus, and it's going to go this way. Okay, so the positioning for this is you're going to place the patient either lying down or seated on the table with their leg fully out. What you need to do is you have to flex that foot so that the plantar surface is near perpendicular to the IR. And this is kind of difficult to do. So sometimes what we do is we get some tape and double back it and have the patient hold it like this so that they can help pull their foot back. It's not going to be comfortable, but we have to get as much of that foot back up and out of the way as humanly possible so that we can see the back part of the calcaneus. So what you're going to do is you're going to angle 40 degrees cephalic, so about like this, and it's cephalic towards the head from the long axis of the foot. So you've got to think of it like this, and you're going to shoot down into the foot, okay? You're going to collimate closely because you want all that KVP to be centered into the foot to try and get a good image of those thick bones that are in the foot. So on the position, we don't want any rotation of the foot like this. It needs to be straight up and down. We need to have it in a proper 90-degree flexion, and 90 degrees is going to be like this if our IR was straight like this, okay? And it's going to be hard. I can barely do it with my own hand, so imagine people trying to do it with a foot that hurts. Let me show you what the projection looks like. So here's what the projection looks like, okay? This foot is straight up and down, and I always say toes pointed towards the ceiling. This is a good 90-degree angle, and this person isn't having to pull their foot back. It looks like they can do it pretty well without any help. This is a 40-degree angulation into the mid shaft of that, the middle of that foot right there. And here's what we want to see. Right here is the base of the 5th metatarsal. So this is the lateral side of the foot. And over here is the cuboid bone. Now this is called the planto-dorsal projection because you are going through the plantar surface towards the dorsal surface. Okay, let me show you what we're going to look for on these projections. So right here we have this big white part, and it's really hard to see through. This is the ankle joint, okay? This is the sustentaculum tali. This is the little part that sits off the side. Here is the base of the 5th metatarsal. Here is the lateral process of the calcaneus bone and the tuberosity. So what idealistically I would like to see is the subtalar joint. You can barely see a little black line right here to see the subtalar joint, but for whatever reason this was in the book and they didn't show it, so I'll find another picture. So the lateral projection is the easier one. Obviously this is going to be the lateral, and you're going to have the foot laying over. All right, so same SID, you don't use a grid. The KVP range is going to be about 60 to 75. The patient needs to be laying down, and their foot needs to be all the way over on the side. So what we do, and I can't show you this in my office, but it's easier if you lay them down and have the opposite leg behind their other foot. Okay, if they're too big, they're going to find this is very difficult to do. You can even bring their other foot forward to give them that security so that they can place their leg down in a purely lateral position. So for the CR direction, you're going to direct it about 1 inch inferior to the medial malleolus. So what you're going to be doing is shooting medial to lateral. The lateral side of the foot is going to be laying down on the IR. Okay, 1 inch inferior to the medial malleolus. And it's pretty much just right there, shoot at the calcaneus. All right, let me show you a picture of what this looks like. All right, I don't want you to look at this picture. This is the picture that's in the book. I don't like this picture. Because the wedge right here that is under this person's foot is going to make this calcaneus foreshortened. I don't think they thought that through when they were doing it. And it's too collimated. I need to see more into the midfoot area. See, like over here is a great example. This you can tell is directly lateral. straight, 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 and you can see the bones up in the front. Okay, this picture right here, I don't know why it's in the book. Now, yes, if you need some help getting the foot straight lateral, you could put something up underneath the toes. You could put something underneath the knee to help make the knee roll over just a little bit to bring the foot forward a little bit to make it a little bit more lateral. However, it's it's going to be patient dependent. A smaller person is going to be fine. A bigger person with a bigger leg is going to have a little bit more difficulty. So here's what we're going to be looking for on a lateral calcaneus. Right up here we have the navicular bone, remember, and then we have the cuboid bone. Over here off to the side is the base of the fifth metatarsal. This is the talonavicular joint, and this whole bone right here is the talus. Remember, the talus is on the top. Up here we have the tibia, and the fibula is on the other side. So this is actually laying on the lateral malleolus, and you want to center your IR right about here to the sinus tarsi. You're just going to aim directly at the, so here's the, take the ankle right there in the middle. All right, from the calcaneus to the top of the foot, just aim right in the middle. Here is the calcaneocuboidal joint. That should be a nice joint space right there. And here is the calcaneus. This is the tuberosity. Let's go to the next one so I can show you some wild stuff. So here's some calcaneal fractures that I had found. This is an avulsion fracture where the Achilles pulled up and broke the calcaneus in half. And here is what they do to go in and repair that little guy. So if you can see down here at the bottom of the calcaneus, this is what's known as a bone spur. Now, here's the secondary picture of that. You can have bone spurs and not have pain. You can have pain and not have bone spurs. So I want you to remember that a bone spur is not necessarily the reason for someone's pain. All right. Here is a bigger or another example of a calcaneal fracture. And here's where they came in and put in the screws. Now, if you notice, what's happening here is how the bones are all nice and white. And then after a while, you can kind of see through them. That's called disuse osteoporosis. This person has been non-weight bearing on this foot for quite some time, waiting for this fracture to heal. And what will happen is when the muscles become so lax, the muscles are actually what helps, keep your bone strong. So disuse osteoporosis will happen whenever somebody becomes non-weight bearing for a while, and they have to rebuild their muscles back. Here's another surgery that didn't look like it quite did so well. I see 2 screws here. Maybe that was a previous fracture. And then there's another fracture right here. So they had to come back in and put in 2 more screws. Isn't that awesome? That's crazy. All right, so that's the end of calcaneal fractures. Yay!